Here I'm going to call to the stage Shahzad, who I've already learned incredible amounts from. I've known Shahzad for over 15 years, maybe longer than that.
18.
18 years? Wow. Time flies, or whatever. Shahzad is going to come up and talk to us about how healthcare tech is going to evolve over the next 5, and I'm super excited for this talk. So come on up.
Thank you.
Thank you. Clicker's right there.
All right, thank you, everyone. and the story is actually when I started at Cerner in 2005, Aaron was my IP ambassador, so he was the one who was mentoring me earlier. So I have learned a lot more from him over time as well. So thank you, Aaron, and thank you for the wonderful conference we have put together. So as we get started, what I want everybody to do is take out your phones or devices, go to menti.com, put in that code, and I'll introduce myself while I'm talking, but while I'm talking, if you can try to take this survey, we'll see if this technology works, because it's not my computer, so that's the risk I'm taking here. But we'll learn as we go. So, as I said, I am Shahzad Zafar. I'm the CTO for Trualta. I've been in healthcare pretty much all my career, as I said, starting from Cerner and coming over to, I did Rx Savings after that. For the last 5 years I was there, and then about a month ago I joined Trualta. My healthcare background has been learning from some of the best that we have had at Cerner, and what Cerner did through its transformational years in the, call it the heyday. 2005 and onwards, there was a rapid growth of Cerner. Most of you in Kansas City, so I think half the room's hands went up when we talked about who had a Cerner history or pedigree. That's where I learned a lot about Cerner healthcare and technologies and built my passion about healthcare. As I left Cerner, joined Rx Savings, which is a prescription benefits tool. Again, we were running a lot of machine learning and also working with prescription benefits, and I learned a ton about how prescription software, healthcare software kind of works together. And my latest step in my journey is now at Trualta, where we are a caregiver education and support. So again, working with individual users and talk about what is happening in healthcare. So today's talk looks like the poll is not working, so we will wing it. But today's talk and today's agenda we'll talk about kind of what have some of the trends, recent trends in healthcare, but really focus on where I feel like healthcare is trending to in the next 5 years. My hope out of this, and that in the end we get to a point where you all have a tangible takeaway, and hopefully you are inspired to go do something. And participate, be a participant in that journey. We can move to the next slide. All right, the current state of healthcare. So if you think about interoperability, that has been the buzzword, I feel like, for the last 10, 12 years in healthcare. It has been all about interoperability. You heard about any HL7 experts in the room? Ooh, one, all right. And then came FHIR in the last couple of years, trying to make it all REST-based and nice. But interoperability is still far from being applicable in healthcare. So if you are, especially if you're somebody who is dealing with a chronic condition, or not even a chronic condition, even with my own kids. My kids go to an allergist, they go to a pediatrician, and I can't get those records to work together. Like, it seems so simple to us as technologists, but it's like it doesn't work. So interoperability, while we have moved a lot, there's still a lot of that exchange, but there's still a lot of room to grow. COVID-19 had a huge impact. So 2020, we have, I heard mentioned earlier, had a huge impact on how healthcare is delivered. We learned about gaps in our healthcare system. We learned about accessibility, lack of accessibility in some areas. We learn about the stresses on the system, especially when it comes to like staffing challenges. So we weren't able to get nurses in or physicians in. Those are all the things that cause a lot of problems and stress to our healthcare system. And not just in the US, it happened globally. Similar things happen. And on the last point, the funding and revenue challenges, on one hand, when I was putting it on, I'm like, man, we hear about all these numbers of health plans and health insurances and hospitals making billions of dollars. But at the same time, there's a lot of funding challenges. There's a lot of concern around how much revenue they're making. So they're trying to maximize. If you go talk to a health plan, they'll point to somebody else. You go talk to the hospital, they'll point to the physician. You talk to the physician, they'll point to the hospital. It's like there's just so many elements in that funding system that overall it causes a lot of stress to the consumers of healthcare. So these are kind of some of the current landscape, the current challenges that we have in healthcare today. So moving forward, when we talk about the digital health transformation, we have made huge strides from when I first entered this industry in 2005. So since then, we talked about interoperability. Meaningful use came in, if for those of you remember, and it propelled electronic medical records to the next level, right? That's what Cerners and Epics, Boon Days, they made so much money on those because everybody was going to an electronic medical record, which was great. It digitized the record to an extent. It did not make it fully accessible and shareable. Where I think where it goes in the next, and we'll cover this next, is we will have sharing of data will definitely change. And I'm not going to spend too much time in interoperability because that's going to be an ongoing journey. But we have had some other advancements that have happened more recently, kind of around genomics. You've talked a lot about AI so far, and I'll hit it briefly as well. Variables where they have been beyond Fitbit, what can we do to make it even more easier to use? And telehealth, and I'll approach telehealth from a different angle, not just a ZocDoc type of model, but what does telehealth really mean? So in the start of this journey, where I do believe in the next 5 years, we'll get a lot more is to personalized medicine. Today, medicine is if you have a condition, you have an issue, there's a default treatment plan you follow. Obviously, your physician knows you, they help you to customize it, but when it comes to research, it's for this condition, here's the medicine, you go take this medicine. There's no individualized concept of when we talked about, again, back to accessibility and the research being there to understand that depending on where you're from, depending on your socioeconomic background, depending on your genetics, this is going to be all different. So at Rx Savings, we had looked at a few medications. So we were looking at purely from a price perspective, but we did a lot of clinical research as well. And we found that research exists today that some of your name brand medications that you might see commercials on TV, which were super expensive, those would cost you $3,000, $4,000 a month for one person to maintain that. And you have to take these medications. These are called your sustainability drugs. You're taking them every month. We saw that some of those medications were only effective 20 to 30% of the time because of genetics, because how the genes operated, but they were the most effective, so they were just prescribed because that was what that drug was made for. But how that drug was administered changed if you understood people's genes. And pharmacogenetics, it's hard to say, it's a mouthful, but pharmacogenetics is a budding field right now. So there's work being done in the last couple of years that we have seen, and I feel like every time I look into it, it's becoming more and more advanced. But the idea is that for the same medication, for the same diagnosis, there are multiple ways to deliver that treatment. And that's when I say personalized. It's not the old definition of personalized where it used to be in healthcare. If you get in any healthcare conference to talk about, we need to put the patient in the middle. Which is fine, yes, that is great. We want to surround the patient. We want to make sure the patient has access to data. But this is personalized to you as a person, not just a patient in general. It's based on my background, my genetics. Can we make sure I get the right treatment at the right time? And sometimes that means that the default treatment that is available today might not be the right treatment. You might have to go look at different underlying conditions. So that's where the history behind genetics and combining that with technology. You can throw in all the machine learning stuff on there if you want, but combining that really, I think, gets to that concept of personalized medicine and personalizing care. That I think will definitely be will have a huge impact in the next couple of years. Then we talk about AI. There are three different aspects of AI. There's care assistance for patients, diagnosis assistance for clinicians. I think that has probably gotten more press, in terms of especially in the diagnosis field, especially in radiology type departments. You hear about that a lot, that are being used to the AI might analyze an image and give you a diagnosis. you have research assistants for researchers, which is to say, like, there's a lot of body of research out there. Sometimes you don't have ability to go look at every single article. Can AI help you synthesize it, summarize it, look at the key points? Things like that, where it assists you in getting better. In our company, we use AI. So we are doing care education. But the key point for us also is to make sure how we are using the AI. We learn on talk on the ethics of AI to make sure we have that human element in there of, like, as we are reviewing content, we're using it to help us speed up our research, but not replace the research that we have experts in the field doing. But specifically talking about how AI will be used in healthcare, in my view, the biggest move that will happen is care assistance for patients. So building on the concepts of personalized medicine, how patients view their own healthcare, I believe, will change. You already have a lot of companies that are working on making it all about the patient. And when I say all about the patient, how can I connect my different elements of my care together, right? There have been work that has been done around patient portals in the past. You have had some, Cerner has done it, Commonwealth has tried to do it, some other Google Health, if you remember, which I don't think is running anymore, Google's Health. They had a data platform to try to connect all that. Apple's Health Kit is pretty impressive. It's trying to connect the data. But all of it's trying to get to is it's helping the patient make better decisions. The work we did at Rx Savings, one of our premise was when we started doing that work, nobody believed us because everybody said, well, when it comes to prescriptions, the patients only believe in the physician, which is a true statement. I, by default, will defer to my provider on what medications and stuff we do. But where we flipped the model a little bit was our goal was to educate the patient and help them make a decision with the help of the provider. So how could we educate the patient where when you look at those complicated drug names, you're not just scared to death. You're just like, I don't know what this means. I don't want to deal with this. So we wanted to make it as an assistant. Our whole goal was, our premise was educating the patient, educating them the care options they have, give them the pros and cons, and then they still work with the SME, the subject matter expert, the provider in this case. That I don't think goes away. This is where the job of the provider changes, but where I think AI really helps is, like, instead of you just putting on Google and finding the first thing that tells you that every disease is like the most horrible thing that's going to ever happen to you, it's like, can it help you educate you? Can it help you make a better decision? The other aspect of it is, as we talk about connecting all these data sources, this is a story I heard from a friend of mine who's looking after his mother, and there's a ton of data records. Like, he's going to appointment after appointment, managing some chronic conditions, working with different doctors, and he's using a notepad to keep track of all these notes, and then trying to remember when something happened or when something didn't happen. What did this physician say? What did that physician say? And this is like pages and pages of notes. It's very hard to remember what happened, and there's no record that exists today that will make that happen. So he was working on this idea. I'm not sure where he's at yet, but he was trying to implement some AI things on his notes to say, well, can I ask the right prompt? If I ask the right question, I can get the response surface up to me, so I don't have to go spend hours and hours trying to find what happened. And that's where, when I talk about care assistance, it's like really doing the job. Like, not everybody else can have, you can't have one physician for one thing, right? Specialties exist for a reason. You can have a lot of providers that provide a lot of personalized care. So direct care as a concept came into existence for that reason, is where you get very much of that concierge service from your provider. The idea being the provider is there with you the whole time. But then as you go beyond primary care into specialized care, now you have all this data everywhere. And we always talk about that you want to take your data back to your provider to make sure they have the full picture. But in the end, you and I are the only ones responsible for our own care. Nobody will care about our own care more than ourselves, whether it's our parents, our loved ones, our family, friends, ourselves, for our own selves. So that's where, when I think about the practical application of AI, I think in that personalized, continuing with the personalized medicine, but care assistance for patients, I think will have a big, big change in the next few years, because now we have the tools, now we have the models that can make this happen. Now we need to make sure how we connect it all, feed it the right data, and then we can build on top of it. So, role of 5G. Again, it's like when 5G came out, it's not about just watching your YouTube video faster or your movie faster on your phone. But really, where 5G becomes is that high-speed internet and what it does for accessibility. There are a lot of places in the US you still have an accessibility problem, where internet's not readily available, or it's very hard to get that last mile. Like, we are lucky, or those of us who live in Kansas City, like, we got Google Fiber and it was awesome. Like, 1 gig internet, it was great. But if you go 15 minutes outside of Kansas City, well, you're back to your old standard internet. It's spreading, but there's still parts of that last mile access is still an issue. Last mile access when it comes to delivery. So when, again, it comes to healthcare, for those folks to come to a place to get the right amount of care is really hard. It's expensive. What if you live in a country, which is outside, we're lucky to be in the United States, at least we can drive everywhere. But what if you're in a country where you don't have that access? 5G from that concept is spreading across the world. Now, every country is investing money in it, infrastructure in it. There are countries that don't really have an internet backbone, but they do have a mobile network backbone is everywhere. So that kind of leapfrogged the internet a little bit if you think about it. But that concept of 5G is why I think it's going to be critical from a healthcare delivery standpoint. So when you talk about affordable access to care, so that you can get access to over the internet, and a globalized connectivity and data sharing, it's not just about connectivity that I'm able to connect, but earlier we were talking about having the right data for the right research, right? And in ethics of healthcare, we discussed about how do we make sure that the right research is represented in our care, so that we are all different elements, all different types of people, the diversified group that we have is all encompassed in our care. So can we make that data available to researchers? So while a specific country or place might not have the ability to do the research, but could we provide that data to the researchers more easily? 5G allows, I really do believe, it allows us to make that connectivity a lot easier. So as 5G spreads, some of the applications that I see, and I mentioned telehealth. Telehealth is probably the most obvious one. Sure, we have all used it. Well, I've used it at home just for my own convenience, that I don't have to go to a physician and wait in an office for 30 minutes or whatever. And then if the provider's running late, I'm staying there forever. But telehealth in concept of accessibility, that if I'm in a place where we don't have that specialty, we don't have the provider, can we build these diagnosis centers that are just all maybe telehealth related, where specialists can come and do it? So I saw it in action during COVID as well. An acquaintance, a friend of mine, he runs a psychology group where he hires psychologists all over the US, and they do everything over telehealth. Now, that profession was the best one to start off with from a medical standpoint, but they increased access to telehealth. So made it super popular, not popular, but made it easier to get access to. We have a lot of mental health issues in schools today. There's a company called Hazel Health, and you can look them up. They're doing work on expanding the same concept to schools. So while a school board or a school district might not be able to afford to have a psychologist or a social health worker in every school, but can they scale it using telehealth, where they provide a safe environment for kids to come and talk, and their appointment schedule or on the fly, they can go and talk to those providers and physicians and psychologists online and get the care that they need at the right amount of time, at the right time. So again, back to that accessibility concept, and that's where even if you don't have internet, well, if you have 5G, that allows you to do it. So you don't have to have that full fiber optic infrastructure. As long as we have cell towers and with the devices where they're going, 5G is going to be everywhere. So that, I think, moves. Robotics. So there's the speed of internet is coming to a point where you can do some of these surgeries remotely. I recently listened to a podcast that talked about robotic surgeries happening in Pakistan. So again, did not have access to care, but they're providing remote care in Pakistan to some of the remote areas through remotely, not only just providing verbal care, but providing actual procedures, the ones that they can do at that point in time. But some of these, I'm sure in some sort of a medical show you have seen it being applied, but it is actually real. It is happening today. It's just not as common today yet because we're still building the technology and the fine-tuning of the hand of a surgeon, that can the robot move at the same precision as a hand of a surgeon. Some of those things are still pending, but those are things where it's moving. And again, that I think will increase the accessibility aspect of it. Health monitoring devices, back to, we talked about Fitbits, but now you have diagnosis monitors, everything else, which is traditionally when getting care, you would have to go to a physician to get your blood pressure checked or do something, or sending that report back to your physician would be a phone call and leaving a nurse message or something like that, and then hope it gets to the physician that they'll call you back. But some of the devices that we have today already that exist today, which I think become more prevalent from a monitoring standpoint, is can your record be monitored at all times? If you have a heart condition, can be monitored at all times when there's any issue in your rhythm or anything that happens, the physician, your nursing team, your care team, somebody, your loved one, somebody's alerted who can quickly react to it, where you're not living in a prolonged condition. So if you have a history of heart conditions, for example, maybe you do it proactively, or maybe you're diagnosed and then you start doing it. Similarly, like anything that you can think about that needs to be monitored, your mood, your blood pressure, things like that. How could you make it easy? And I want to tie it back to accessibility, because I think that's the big change in healthcare would be accessibility, is that now I don't have to have that health hospital close to me or this health clinic close to me. I could be living wherever, as long as I got some internet connection, whether it's through your Wi-Fi, fiber, or through 5G, or through your mobile network, doesn't matter. As long as I have that, I can report my healthcare back, or my health systems, or my health data back, and get action on it. So that's where I think 5G and internet in general, I think, increase that accessibility to care for everybody, and definitely it's all within reach at this point in time. We did talk about population health. I think it was in an earlier question somebody brought it up, that they have worked with population health. And I agree with I can't remember who said it, but they said like population health, it will go beyond just looking at that it's find out, I think you said it in your talk, that it's all the people who would have diabetes, like we want to find all the people with diabetes. In my hand, population health goes beyond that, and that goes back to that interoperability of now how we are able to connect the data. The historical problem from what I had seen at Cerner and even now when we're looking at different systems, that it's a very strict protocol to share data, right? Because it's healthcare data. I understand. It's very sensitive. You can't get it wrong. You have to get it right. But it was like you have strict standards that have to be created. Everybody has to follow the standard. Only then we can share data. HL7 existed for that reason. FHIR standards, which was just the fancy version of HL7, it's just a REST-based standard. But it is still a strict API that if I want to talk to 3 different clinics who are more than likely are using 3 different EMRs, now I have to go build 3 different integrations. And that is hard. That takes time. That takes development effort, and it's not easy. While in theory, it's easy. As a CTO, I've been asked, it's like, well, it's just an API connection. How hard can that be? Agreed. It's not that hard. But it takes time. It takes effort. You have to maintain it. As those changes, there's a recurring cost you pay. Where I think it changes is that we are, with the power of some of the machine learning algorithms we have, we can get data in a more unstructured format. The API data exchange is a very, very structured data format, right? You know exactly the field, what it is, and where it's going to go. What I think will make it easier for the data exchange is that you can actually just dump a whole bunch of data, just upload it, and let it figure out what data type is what. And it kind of does the mapping for you, does the work for you, makes those connections easier. In the future, maybe there is a company that all it does is that you can dump all the data you want in there and they spit out some outputs that you have. And when we talk about the data exchanges, I do believe it will go beyond just strictly your EMR data or your EHR data. So what you get at a clinician or whatever. I think, or I truly believe that this will go beyond and you can start factoring in the social determinants of health, like some of that data. Census data. If you can combine census data with health records, it will tell you so much more about a patient than we can ever imagine. Because you will know what type of background they're coming from, what type of limitations they're coming from. That access is going to be very, very exciting. If you think about it, there's a company in Kansas City called Free for Market. It's a pretty small company, early stage company, but they're doing work around food accessibility. Of all the things, they're worried about food accessibility is like, how do I just get fresh foods to the people who need it, right? Again, it's a pretty cool concept that they're doing. But again, it's like they have to know which areas are the gaps are, and they're using some of that data to know where they have gaps and where you don't have an Uber Eats or a DoorDash or anything like that. Those companies work well in a metro area where there's a group of population that's together. But our real struggle comes in the moment you go outside of Kansas City. Most of Kansas is not populated, right? It's very low population, but I can't remember, but like majority of your Kansas's population is either in Johnson County, Topeka, or Wichita. Outside of that, there's no groups of population, very sparse population. So how do you get food and access there? How do you get their data back and really be able to analyze a population and think about what does this population need besides your standard, hey, we need more cardiologist here and diabetic doctors here or whatever, but it's more about, well, maybe it's just about food access. Maybe we just need to solve that. There's nothing else we need to do. Just need to get people access to healthy foods, and that will take care of all the health issues we have. So taking population health, and when I say smart resources, smart deployment of resources, it's not smart deployment of nurses and clinicians. That I think we have already partially done, and that's a given, like, okay, fine, we'll get that. But it's like, what are the other resources we need in those areas? What is missing that will help the overall economic ecosystem in those areas and help raise the bar in healthcare? And that, I think, when we get to true population health management, and with what we have today, or where we're heading towards, I think we'll be able to connect a lot of different data sources. And census data is, again, if anybody's in healthcare, and if you don't look at census data, I would encourage you to go look at it. And try to map that with some of the data you might have in your systems. And that will reveal maybe a new side of your business, a new side of your application that you haven't thought of yet. So again, it's a very, very important concept from that perspective, and that's where population health, I believe, goes. So what does it all come down to? So we have talked about personalized medicine, genomics, population health, 5G, healthcare kind of becoming more value-driven, right? It's what is the value that's being delivered to me. It doesn't matter whether I went to a physician or not. So ACOs, accountable care organizations, have existed for a while. They exist for, again, their whole concept is that that they're accountable. They get paid a standard amount per patient, no matter how long you stay. So they're motivated by quality. That model is still there. Some organizations do it. There's still a lot of issues with it, but which is why fee-for-service exists, right? If I go to a physician 5 times, I'm paying the fee 5 times. Even if it's for the same problem that just hasn't resolved the first time, I'm still gonna pay. Not that it's physician's fault. Maybe they just don't know enough yet, but the point is, it's not on the holistic end result. It's by what service was performed, not by the end result that matters. I think when we are trying to connect all these information together, when we connect when we have that personalized medicine, when I can look at my personal genes and get to a really good diagnosis, and I can connect all these different data sources, then it's all about how do I provide overall care, true health care, not healthcare in a healthcare setting, in a health system setting. It's healthcare when I live my life. So I personally believe from that, we will get a higher and higher push towards value-based care. ACOs might expand from a traditional health system to maybe just a full population. And then your reimbursement models are still probably the challenge there on how financially people will be reimbursed. That challenge still needs to probably, we need to figure it out. Maybe that's the last hurdle, because usually finance drives how you get paid, drives how things will happen. But I think that I think as more people see it, you're hearing more and more about quality of care and how care is delivered, not what care was delivered. It's how it was delivered, and that influences your reimbursement. If you think about star ratings in your Medicare population, those of you familiar, star ratings, if you lose a star in a health plan for a Medicare population, that could mean millions and millions of dollars of revenue losses, because star ratings are mostly all about quality of care. It's not just that what the outcome was. You as a patient have a power, a voice in it that you can say, no, I did not enjoy my experience. While I got better, but I hated my interactions. That will hurt the star ratings. That again is value-based care. So the shift I see is focused more on outcomes and quality, and which again, in the end will help costs, because if I can figure out ways how to keep people, if I'm not motivated by bringing people in to deliver care, but I'm more motivated by people keeping out so that they're healthy in their communities, in their environments, that reduces the overall, that financial benefit or the financial burden we talked about at the very beginning, that reduces the burden on that health system or that provider, but also just says as a community we are healthy because your motivations are different, right? And that's where it all goes back to what you're motivated by. If you're motivated by just getting more people in the door, well, that's how you'll behave. That's how you'll provide care. But if you're motivated by keeping people out, and that quality is what you get paid on, well, that will definitely change the model from being that fee-for-service to more value-based, which I think in the end helps. Sorry, can you click the next? Stops working. Which in the end helps both the patient and the patients and the provider too. Both the health system benefits out of it, and the patient definitely. As patient, that personalized win for the patient and the provider both. So now, I wouldn't be a responsible CTO if I don't talk about what it means for sharing all this data. Right? My other side of my brain that tells me I have to worry about security and small things like that. So we were talking about, I've kind of painted the picture of, yeah, we'll share all this data, everything is great, everything is wonderful, but that's a lot of responsibility. I worry about that every day. Those is like, if you would ask me, one thing that keeps me up at night is always security in our system. It's like, are we protecting the data properly? Are we treating the data properly? As we are even analyzing the data, are we doing it properly? So that is definitely a great responsibility. Cybersecurity in healthcare is a big field. I believe there's a talk later today around cybersecurity and AI, which I think plays into this whole conversation. Person matching, when we're talking about data sharing, how can we use some machine learning models to improve our person matching? So we are, again, sharing the right data in the right place, making authorizations easier. How do I authorize my information for another physician to look at? Again, you have to enable data access, but we have to figure out also how do we do it safely and securely, and keeping privacy in mind. Sharing data does not mean you lose your access to privacy. The data, no matter who you are, and no matter what application you're using, privacy still needs to be top of mind, and we need to remember that. The other aspect of it, and I'll touch on briefly, I think the last talk covered it much more better than I ever could, but privacy laws and state at global levels, they're ever expanding, ever changing in the US. California's privacy laws are probably the strictest in the nation. If you haven't reviewed them, I encourage you to look at them. They're very similar to GDPR. So if you are doing business in California, you have to worry about them. Similarly, other states in the US are enacting similar laws, and globally too, a lot more concerns being put around data privacy and how data flows. Now, one issue that we have today, and maybe at some day it will change, is that healthcare data, for example, it's still hard to move it across borders because of, again, varying laws and restrictions in different countries. But maybe at some day we will have a global standard that will allow us to maybe share data globally a lot more easily in a safe environment. Vetting sources for data for AI models. I think that is such an important thing that we have to remember, especially for everybody here who's working on models and working in technology. Because the AI model, no matter how beautiful it is, the output is only going to be as good as the data you feed into it. If you feed the data in with a certain bias, the result that will come out will have a certain bias. So it's so important for us to remember that we vet the data. Like, don't just use the model just because you have access to it. Figure out what data is being fed into it. That is like people who I've talked to have talked about like, well, AI is going to change the world. I was like, well, it's right now. If you think about ChatGPT and all, like they had a pretty vetted data sources when it was first released. But now over time, as everybody's coming with their own models, what is the source of the data? Pay attention to it. Ask the question. Try to figure out if you can figure out what is the source of the data. Do you trust that source of the data? So, and again, this is where making the data more widely available and accessible is great, but also figuring out that the right data is being fed into it. And right, I mean that it has no biases. It is truly representative of the community we are in. Things like that. Vetting the sources of data are going to be super important. And then lastly, I don't believe that AI will replace the decision that a patient or provider has to make. It will supplement it. It absolutely should. It helps you make better decisions. Hopefully it brings data to the forefront that you haven't seen it and makes it easy for you to look at the full data set and analyze it. But the decision in the end, as people who are building products in this room, you want to always make sure you have to leave the decision with the clinician, the provider, because the moment you take that away, that's when you start losing trust very fast, and that's when it'll start to unravel again. So how do we make it where it's responsible in the sense of like we are giving that access, we are providing that access to clinicians and patients, leaving the decision with them while making it fully accessible. So with that, two key outcomes. Personalization and access, I believe, will be the key. Personalization, again, back to the person, that it is about me as an individual, not me as just a patient in the system. Like, how do we make my care better? Being able to access that information. And I do believe that technology in this place will help with the cost aspects and make it cheaper or more affordable over time. And it's not just for the health systems, but also for folks who currently don't have access or it costs them a lot to get access to care. It will become easier as we move forward. So with that, we'll land. And all right, we got some live polls are dangerous. Yes, whoever said that, thank you. So it worked for this one. Somehow it got messed up for the first talk we did. So anyway, thank you everyone. I'll take any questions. And again, if you want to still answer the poll, feel free to. Would love to hear any takeaways, and hopefully that reinforces for you some things before you walk out of the room.
So while we're getting set up for some questions or whatever, one thing that strung through the talk that I thought of is, like, I heard Neil's voice of the separation of health and care or whatever. Some of the greatest things I think I worked on in my life were about preventative medicine, as opposed to, like, the patient's already sick and in the healthcare industry. Like, how can we prevent that type of stuff? But the thing that just knocked my socks off is, and this is what I was mad about at the beginning of the day, is like $3,000 to $5,000 a month for 20 to 30% efficacy. Like, this has to change. This is awful. Like I've shared with Dustin and Ben a lot. Like, I experiment with myself. On my favorite chemistry project or whatever, I spend about $5 to $10 a day on supplements of taking either pills or powders or whatever, just trying to figure out, and I measure everything. I've got 4 different apps on here. I've got my Fitbit and everything or whatever. And I feel like that's what we need to turn healthcare into. Like, but maybe not everyone has to be as crazy as me. But
not run experiments on yourself.
Yeah, well, experiments on, like, I mean, maybe we get back into the AI discussion about whether we should do that on other people or whatever. But we got a question here?
When it comes to self-care and self-diagnoses, this is one thing, the more that we see personalized health apps, there seems to also be a concern, and I'd say rightly, from the practitioner community that people are going to be think they have more information that they can begin to do self-diagnoses. And do you see that there are actually inherent risks that there's more consumer available information that they may then be less likely to visit their practitioner who they have to pay to go see?
Yeah, and I think definitely there's a fear about that you'll see something online, but that exists today. I don't know if that changes with Google and WebMD, and you can go put anything on symptom on WebMD, and it will
Whatever
have
you
the worst
ask, it's
possible
lupus
diagnosis.
and cancer, you're going down.
Exactly. It's leading to your death immediately. So I think that fear exists today. I think instead of like fighting against those apps, I'd say we should figure out a way how to work with those apps to help patients decide better. And in cases where it is simple enough, but I think the disclaimer should always be, hey, review with a provider. But maybe some of these apps make it easier where you can just virtually or just say, I think this is it, send your symptoms to a physician, and they asynchronously reply that, well, okay, no, it's just an infection, go take this medication. You can make that ecosystem a lot more smoother where you don't, again, it's like, today, a physician, when you call them up, they're like, well, until you come and see me, I can't charge you, so I'm not going to give you a virtual diagnosis. Or I'm not just going to tell you on the phone, unless it's a friend of mine. But if you're able to get away from that, then you can make that, again, is you build the right incentives in to change the behaviors, and then you can more easily make that, where providers spending less time trying to shift through all that information, patients can do it on their own. We're very smart people. Look at it, see it, confirm, and then get care from there. So, other questions?
The talk was too good, you covered it all.
Thank you. All right, well, I'll hang around.
All right.
If there's anything.
Thank you so
Thank you.
much.
Thank you.